been so much in 2025 that has changed my day-to-day clinical decision making. I don't know where to start, but I think I would say some of the biggest changes have been the updates to some of the guidelines. We know earlier this year we got a new set of hypertension guidelines that talk to us about really treating blood pressure earlier, treating it at lower thresholds, and treating it more aggressively. And I think that's a theme in many of the guidelines, because we also got a new set of acute coronary syndrome guidelines that talked about getting that LDL down much lower and doing it with combination therapy up front. We saw updates to the pregnancy guidelines. We saw some updates to the valve guidelines from the European Society of Cardiology. So lots and lots of really interesting incorporation of new science into the guidelines that I've brought directly to my bedside. A few other things that I really have changed based on advances in 2025 are risk stratification and risk prediction. And that's using some of these new scoring systems, the prevent equations, of course, we've talked about, the SCORE equations, the SCORE2 equation, which is a risk prediction tool validated in a European cohort. These are helping us to not just find people more specifically, but find people who are higher risks, really be better in terms of predicting risk. And I know for me on a personal level, I've been using a lot more GLPs as well. So the idea of treating cardiovascular kidney metabolic syndrome, I think is one of the most fundamental paradigm shifts that we've also seen in 2025, where we've gone just from the internist or just the endocrinologist thinking about diabetes to cardiologists thinking about diabetes, chronic kidney disease, urine albumin to creatinine ratio. So that's been huge. I've also really appreciated the onset of many more tools that are evidence-based in treating HFpEF, or heart failure with preserved ejection fraction. A few years ago, that was a disease phenotype which we had nothing for. And then, of course, the SGLT2s broke onto the scene. Now we have non-steroidal MRAs. There are ongoing trials in the GLP space to see whether this can modify HFpEF outcomes as well. So that's been huge. And I would say the biggest one for me, honestly, as a clinician, is using an AI scribe in my clinic. It's completely changed my life, because the burden of charting and doing charts late into the night is something that we've all experienced and we had been dealing with and struggling with for many years. But in the last year or so, I've really seen a shift, not just in my practice, but in the practice of many large health systems like Kaiser and university hospitals and others, where they're incorporating these AI tools into our clinic, which don't just help sometimes with scribing, but potentially in the future may even help with clinical decision making, putting in our orders and offering clinical support. So what a great year to be a cardiologist, because there's just been so much that has been in the science and in the guidelines, and I look forward to next year as well. There was so much great science that came out this year and so many different spheres of what we do as cardiologists. So I'm just going to pick out a few that were some of my favorites, but I'm sure there's many more than what I discussed today. So the aquatic trial, which was a trial looking at patients with both atrial fibrillation and coronary artery disease, really asked, do we need more? Is more always better? Oral anticoagulation plus low dose aspirin, is that better than just oral anticoagulation alone in these patients with both of these comorbidities? And what they found is there was actually a signal for harm. So major adverse cardiovascular events were 53% higher, and bleeding was more than 3 times higher in the dual arm, where you're layering the oral anticoagulation on top of the antiplatelet agent, the aspirin. And we've seen similar clinical data with agents such as clopidogrel and other antiplatelet agents. So to me, this has really driven home the point, and I'm actively stopping antiplatelet agents in my patients all the time, which is that we really need to get rid of this kind of layering approach of an antithrombotic plus an antiplatelet in patients who have multiple comorbidities. So I'm only using oral anticoagulants in patients with both AFib and a high CHA2DS2-VASc score, as well as coronary artery disease. So that was the aquatic trial. Staying in the AFib space, I also thought the closure AFib trial was really interesting and sort of practice changing in a way that I don't really know what to do with it quite yet. And what this was a real world study. It was not funded by industry, interestingly enough, looking at left atrial appendage closure devices in patients that have AFib and are high risk for stroke, but also high risk for bleeding. And it was a whole host of different closure devices, not just the Watchman, but many others as well, as it was a real world study. And again, what they found here was a higher risk of MACE, which was a combination of stroke and systemic embolism, as well as bleeding. So this was a bit of a head scratcher because normally you would think that you're putting in a closure device to get somebody off of the anticoagulant, they would have a lower risk of bleeding, but that higher risk of the combined MACE was driven mostly by procedural bleeding. So you're paying a pretty heavy price to go and close that left atrial appendage because of that procedural bleeding, and you may not be doing your patients a service. So I don't know where the chips will fall when it comes to the closure devices. I'm waiting for the Champion AF trial, which is going to report out in 2026 to really see what happens. But that's another one that really got my attention. Now I want to shift a little bit to the lipid space because that's near and dear to my heart. And the Vesalius trial, which was really incredible trial that actually led to a label change using evolocumab, which is a PCSK9 monoclonal antibody inhibitor in patients in primary prevention. I mean, this is another paradigm shifting trial because it's basically changing the way we think about lowering lipids to not just secondary prevention, but now primary prevention. And what we saw was there was a 25% reduction in the 3-point MACE, a 29% reduction in the 4-point MACE, and a 36% reduction in first MI. And this was in patients who had never had a clinical event. They had never had an MI or a stroke before. And so again, a very different way to think about risk prevention. And similarly, we saw an oral PCSK9 inhibitor in the Coral Reef trial, which was enlicitide, which reduced LDL by 55%. So for those patients in which the injection every other week may end up being a barrier, we now potentially will have an oral option as well looming on the horizon. I thought the baxdrostat data, which is that aldosterone synthase inhibitor, where it prevents, synthesis of aldosterone, was a really interesting way to treat hypertension as well, particularly resistant hypertension. So potentially another tool in our toolbox. And really interesting also to think about risk prediction, because for the longest time, we've really been using mostly clinical scoring systems. Sometimes we throw in some biomarkers, but this was looking at the fat attenuation index around the blood vessels on a coronary CT angiogram. So not just looking at whether there's already a blockage there, but these are patients who already had a calcium score of 0. And they looked at the fat attenuation index around the blood vessels, looking really for perivascular adipose deposition. And they found that it was a better predictor than inflammation and better than many of the other tools that we currently have. So I'm excited about the future of risk prediction and how we can use imaging as a way to be sort of smarter and to predict what's going to happen in the future. I'm really loving that we're shifting towards precision cardiology because for the longest time, it's been a one-size-fits-all approach for all of our patients. And we tend to be lumpers in medicine rather than splitters, right? Because that's how we do clinical trials. We lump patients into groups in order to study diseases. But really, when it comes to the future, thinking about how we ought to treat disease, it really needs to be a precision approach. So I think where we've made tremendous advances with this is first with something called a polygenic risk score, where you're actually thinking about looking at a patient's genome, looking at their hardware, how their genes are, and really using a genome-wide association study to predict the risk of disease using this polygenic risk score. And I would love to start incorporating this into some of my clinical risk prediction tools as well in my practice, because that's a great way to figure out what's specific to that patient rather than this nebulous concept of family history just kind of thrown in there. How much weight should we put on that family history and towards what diseases? So that polygenic risk score, I think, is really great. The other place I've really seen advances is really using AI to personalize prediction and disease phenotypes. And a great example of this is using AI algorithms to look for hypertrophic cardiomyopathy, not just on an individual level, but really on a population level, to look at AI algorithms on EKGs in general, to look at how the heart may be changing over time. And this is really the idea, again, of personalizing the disease phenotype to the patient. So you're not saying every single patient with hypertension remodels their heart in the same way, but you're actually putting them into different disease phenotypes. So that's been really exciting too, to try to individualize the treatment approach according to polygenic risk scores, according to obviously the current existing tools that we have for risk stratification, but also according to some of these AI algorithms, which can compute things and predict things in ways that human beings probably never can. Now, I do think there's still some gaps that we need to address moving forward. The first being, of course, that we don't have validation for many of these AI tools. So if we're going to start using them in many of our clinical practices, especially for big things like risk prediction, we really need to think about finding some validation. And I'm hoping some of the science in the future really helps to sort of validate these tools. Eventually, what I'm hoping for, if they do get validated, however, and this is where I hope the future is headed and where there's still a bit of a gap, is that we can use this to personalize even the pharmacotherapy that we choose for our patients. So, for example, a patient comes into the clinic and has new onset hypertension. I look at their genome, I look at their biomarkers, I look at their metabolic profile, and then based on that, AI helps me predict which medications are the best ones to treat their hypertension. So I'm not starting every single person on the exact same cocktail of thiazide plus ARB or calcium channel blocker plus thiazide or what have you, but I'm individualizing the pharmacotherapy according to their specific risk. So I think the future is wide open when it comes to things we need to do. Of course, one big gap that I'm always worried about as a clinician is data safety and consenting patients. As we get deeper and deeper into the world of AI, we have to be careful, especially if you're using an AI scribe and AI is listening always in your clinic. You want to make sure that you A, consent the patient, and B, understand what's going to be happening with that data once that clinical encounter is complete. I think that it's been a really great time to be a cardiologist because there's been such an explosion of science. But I think what really needs to be addressed in 2026 is how we think about the future, how we start to screen patients on a population level that's more efficient using wearables and digital technology and those types of things, rather than waiting for the patient to come to your clinic and start the encounter, because that's already requires some activation energy. It already requires some degree of, patient motivation. But how can we bring the medicine to the patients where we can start to screen them on a population level using many of the tools that they already have in their lives, such as computers, such as artificial intelligence, such as many of the wearables. So I think that that's going to be a really important goal moving forward. I know for me as a clinician, one of the challenges continues to remain as we have more and more and more and more medications in our armamentarium. Which do we use when and in which order? And how do we make these medications more affordable to our patients? So I think that that continues to be a huge significant barrier to the way many of my patients can get care, because I often have to choose. It's like choosing between your right arm and your left. Do I start this patient on an SGLT2 or do I start them on a GLP? And I shouldn't have to make that choice as a clinician. I should really be able to use both, because we know that there are parallel risk pathways that reduce risk. But when it comes to polypharmacy, when it comes to tolerability, and when it comes to cost, we really do need to figure out whether it's a polypill approach, whether it's using caps on how much, insurance charges patients for brand name medications or what have you. We really need to have some regulatory changes that can make many of these therapies affordable to our patients. So I think there's a lot of work to be done in cardiology. There's a lot of great science, but in addition to the science, I'm hoping we can start to incorporate some of the implementation of the science, both on a screening level, meaning better assessing risk, getting patients in the door, treating them more aggressively, but then also on an implementation level. Treating them aggressively doesn't just mean writing a prescription. It means making sure they can get that prescription, making sure it's not burdensome for them to be taking so many medications.